So what we are discussing is an unstable fracture, and added with the lateral wall instability that we are discussing here. And there is enough literature in this subset of the unstable extracapsular fracture where the lateral wall is also broken and it is almost unclassified. The problem here is there is no platform. There is no platform laterally, and there is no smooth sliding surface. That is the issue here, sir. And that we are going to tackle. Another is a medial migration, unwanted collapse patterns, different unwanted collapse pattern. Now let me ask the opposite team now, Dr. Agassi sir team. What is your say here, sir? Immediate post-op X-ray intramedullary nail with good anteromedial reduction, good valgus, right implant choice, perfect placement of implant by the surgeon. What do you feel? What will happen?
It is a zero reduction, no?
It is a zero reaction. It is a zero reaction, but yes, anteriorly it is a good contact. As per his principle, there is a good hitching of the anteromedial cortex. What will happen, sir?
Now you show us that it is opened out.
No,
now you show us that, Navin.
Navin, though it is a zero reduction, if the valgus is normal, see, there is a medial void. Whenever there is medial void, additional 5-degree valgus is always required, which is not there in this case. It is going to have a varus cutout in this case.
Let us see. There. What happens? Now see, it has gone into the little varus.
Yes.
It has gone into the little varus because the whole lateral side, posterolateral side is not protected here. See, you can see the anteromedial is protected, but the posterolaterally there is no protection here. So it has allowed some varus, and that varus has created into a fixed angle implant, and it is a cut through, not the cutout. It goes medially, medial migration. Cutout will not happen because it has a very good rotational stability. Implant has a property of very good rotational stability. So that this is the problem, even with the anteromedial reduction.
Is this a spiral blade?
Yeah, it's a spiral blade. It's a PFN A2, sir. And that is the problem. Even with the good anteromedial contact, very good hitching of the anterior cortex, still there are problems. That is the problem in the literature, sir. Another case, see how it has happened in there. And particularly in follow-up, you see there is a breach here. And ultimately, it resulted into a replacement. So this lateral unseen crack was not seen, and this posterolateral part was unsupported, and so there was a toggling continuously, and that toggling has led to, and the varus had made it in a fixed angle, and that fixed angle has made it to the medial migration.
There is no reduction anteriorly also, no?
Now it has gone, sir. This was the position.
You have a first X-ray where there is a good reduction?
This is the first X-ray, sir.
No, these are two different cases.
Same patient. No, I am not showing different patients, sir. I am showing the follow-up.
Okay, fine.
This is the follow-up when the varus has occurred, slight penetration had started, and later on the full penetration has started. At that time, you can see very well there is a lateral cortex, his breach is here already.
Yes, Navin, that is the one of the problem with this headless screw. If the back end of the headless screw enters into the medullary canal, the hole in the lateral cortex will not match. So it will hit against that, and there will be either penetration or it will lead to this fracture.
But still there will be a varus. 2 degree of varus locked the system. That doesn't allow collapse. And so the toggling with the instability, which is the invisible instability, many times we do not see the posterolateral instability, particularly in elderly. With the low musculature, it doesn't give a support. That is the problem.
Sir,
Another
Navin,
case.
Sir,
Navin bhai, sorry.
Yeah.
Navin bhai.
हाँ बोलिए.
This is not a dynamic implant. This is a static implant.
No, sir. It is a dynamic. It is a collapsible implant.
No. But once your screw is inside the bone.
It is screwing there.
No, sir. It is collapsible in that 130 degrees, sir.
But the screw, your outer border of the screw, it has gone inside the bone. It is not outside the bone.
Because of the toggling, sir. Because of the
No,
toggling.
at the moment,
No.
here in the first X-ray, you go back in the first X-ray.
First X-ray
Same
also it
thing
is inside.
It is
No,
inside.
sir. It is out, sir. Here you can see it is out here, sir. Very well out, sir.
So, Navin bhai, a
Agreed.
different question for you.
Agreed, Navin.
Yeah. Yeah.
Yes, it is out, sir. It is
It's
already out.
correct. It's a Navin. It's a sort of Z effect that has led the screw to go inside.
Why there is a G effect? Because the instability. G effect is an indirect evidence of the instability even after the fixation.
Yes.
Navin bhai, if you can move this arrow, this red arrow jara baju mein.
Yes. मेरे को escape. I have to escape.
Can that be moved? Because
Yes. You want to see that reduction. I know.
yes, I would like to see that reduction.
So, Navin bhai, if this crack you had seen on table, what would you have done? Perfect reduction.
I would have supported. I would support it with the plate. Supported with the plate.
And you think then this migration would not have happened?
Yes, then the toggling will be prevented. That instability will be taken care of. Once the instability is taken care of, it is the whole game of instability, nothing else.
So
each fracture has a different instability. Each fracture has a different bone musculature stability. Each patient has a different bone musculature instability. So when we require a lateral stabilization, that is a question mark. We want to come out with the stability score of different points that we are trying to make the stability score. And then we can decide whether this patient is requiring the lateral stability or not. But till that time, we are doing some overwork, or we are doing 1 or 2 patients out of 10 more precocious and putting the lateral plate. But that is worth preventing the further complication of medial migration or losing the head without salvaging. That is a problem.
Dhaval, if I may, if you look at
Now, sir, Agarse sir, can you see the lateral view without the arrow?
Yes, my observations are two. One is, Vivek, just 1 minute. See this, there is a distinct defect medially. As
no, sir.
Shiva had said,
in AP, yes. In AP, yes. It is a comminuted fracture. It is a comminuted fracture.
Correct. So here, one could have a positive reduction with a little more valgus. Then you will have a good medial support also. And even this, if you trace these two lines, let me get the...
which line you want, sir? I will draw it, no problem.
Yeah. So if you trace the neck, it comes somewhere here.
Okay. AP?
So this is, no, I am talking about the lateral view.
You are talking, I have drawn the lateral. Is it okay, sir?
Yeah, so that's what I'm saying, that it is a little not hitching.
So,
But everybody accepted this reduction.
No, it is not a question of reduction alone. Your screw is almost penetrating the joint. So as soon as it collapsed, the screw migrated in, and there was no control over that, and therefore
but you say this implant has no collapse. It is not a collapse.
I am talking. There is a collapse. There is a collapse. The tip apex distance is the screw tip is almost entering into the joint.
Sir, it is not a collapse. Sir, it is not a collapse. That implant length is same. It has gone into the varus, and then the toggling has occurred.
Yes, that's right.
Then the toggling has occurred.
Navin. We are supposed to
It
discuss the lateral wall.
It is not a collapse of the fracture. It is an inward movement of the implant.
I feel adding a lateral wall plate would not have prevented this inward moving at all.
Yes, it
prevents because the tip apex distance is just barely about 5 millimeters. So that hold was not there. And the moment the varus happened, the screw penetrated into the joint.
It is a good TAD. It is a good TAD, less than 25 TAD.
1 second. I think we are repeating the same thing.
Sir,
repeating the same thing. Arguments are repeated again and again. So can you please proceed?
Yes, the loss of reduction occurs on the toggling, and
you made your point. Navin, you made your point. Please proceed.
Now the second case, sir. Anybody from the other team want to say something about this fixation?
Sir, rather than case discussion, do we continue as a debate?
No, that is the point. Then I will continue, sir. Only 1 or 2 cases I have put just to...
See, the nail is working as a spacer. No, nail is working as a spacer. So...
No. Other team. Siva, you are a faculty. Other team member. They are saying the anteromedial reduction, anterior, there is no gap. Here, there is no combination. And anteriorly, there is a good reduction with this implant.
But this also is in varus because there is opening up of trochanter. Though it doesn't look
It is not in the varus, Shiva. Please.
Neck shaft angle is good. Neck shaft angle is good. But
Yes,
that doesn't mean that the implant is acting as a spacer. There is no kissing of the lateral fragment with the medial fragment. It is not going to unite that early. That is
Anyway, whatever the diameter of nail, that will remain there. There won't be any kissing anytime.
You have to make a space. Navin,
Shiva, if you call this a varus, then I think it is too much.
Sir, I am not calling this as varus. I am telling that the insertion of the nail is a spacer.
It's wedging.
That is the problem. Nail is separating the intertrochanteric fracture at the entry site.
Sir, if the nail has made a wedge, it would have gone into the varus from the initial. The surgeon has already carved the window inside the proximal fragment and then inserted the nail and kept it into the valgus. And it has not gone into on introduction of the nail into the varus, sir, here.
I will accept that without seeing a PDF, both hips. Yeah.
Okay. This was the follow-up, right? As you see, there is nothing to support posterolaterally here. Again, same thing. It looks good in the follow-up, but as you see, it goes into the varus, and that neutral reduction goes into the negative reduction, and due to the varus, their toggling has started, and now it has penetrated also inside the joint. Here, the length of the that was not an issue here. Was it an issue, sir? Vivek, sir? Dr. Vivek
here was not, on the anterior side, the helical blade is too far close to the anterior cortex.
But overall, there was a distance. The
distance, I'm happy with the TAD, but it is not center.
But still, it has gone in the AP also. It has gone in.
What is wrong with the TAD?
Once it collapses, it will migrate in, na?
Yeah. Vivek, what is wrong with this TAD here?
On the AP, there is nothing wrong with the TAD, but if you look at the position of where it is touching the anterior cortex.
Sir, it is not 180-degree lateral X-ray. It is with the anti version you are seeing.
Well, if it is not 180 degrees, we should not comment on the anterior-medial side.
My limited point is, even after the fixation, there is an instability and there are chances of displacement of the neck elements.
Navin, these two are different cases. Go back to the first one. Yes, it's go back the one slide. It's a left side hip you are operated where the lesser trochanter is intact. Now you go back to the next slide. Now it's a right side hip with the lesser trochanter is broken. No.
Let me check whether slides are changed. Just a minute. Just a minute.
The lesser trochanter is broken, which is not broken earlier.
Navin.
No, it is same. It is.
No. Lesser trochanter is broken now. Here you can see lesser trochanter is broken.
These two cases are same, sir.
See.
Okay,
Navin,
the limited point.
If you are saying,
Can you go one slide back, Navin? Can you go one slide back?
Yes. Here the lesser trochanter is already broken.
One slide.
It is broken, sir. But it is broken.
Another question that I have. If you are saying that you are commenting on the lateral view, saying that the reduction is okay, and now you are saying it is not a true lateral, then you get a true lateral.
Let me check one of the slide I may have made hidden by accidentally. I will check later.
Navin, these two X-rays are different patients.
But the only issue is the base surgeon, base implant, base reduction, base placement. Still there are problems.
But so Navin, we should have the same patient. No, these are different looking patients.
These cases is okay, but previous case it was all okay, sir.
ध्यान भटका रहा है.
नहीं भटका रहा हूँ मैं अभी बताता हूँ sir let me.
But if I go one step forward, even if there is the LT is avulsed out, do we do anything for the LT ever it is required?
We do not do
nothing for the LT.
And in this
so
case,
that's not the issue at all. Even it may be two different cases, but one day the LT is away and still it is collapsed. So LT away has nothing to do with it.
Sir, Tanna sir, I would like to disagree there because the nail has been used as a spacer without making proper centering out hole in the nail. So
again, Shiva, you were talking different, I am talking different.
That's what I am
talking about is
no, that's why even though the lesser trochanter doesn't play a role, here in this case, definitely the lesser trochanter broken and also the nail working as a spacer. There are two things which are not good for the fracture to go further.
So
That's why
will
it
a
has failed.
will a lateral wall fixation make a difference in this case?
See,
Yes.
it is a normal
Yes.
lateral wall.
Let us see. Let
It's a
us see.
normal lateral wall.
It's a normal
No,
lateral
no,
wall.
it is breached by the larger size of the implant. It is an intraoperative breach like a DHS. It is
And
an
if you go back, so sorry, if you go back in the X-ray, you can see the lateral wall is separated out. Can you go back
Yes.
one?
Yes.
Just one back.
Yeah.
नहीं, इसमें भी नहीं था.
So
No,
lateral
the
wall is
lateral wall
intact.
is not broken, sir.
Sir,
Lateral wall is intact.
if you are not seeing the larger figure, that's why
Now,
I'm
now
marking.
here,
I can
here,
mark
if you
it here.
see, nahi, here if you can see the whole that piece is completely separate.
Yes, that is separate totally. But
Yeah.
that was not noted by the surgeon. That is the issue. That
चलो
was
आगे
noted
बढ़ो,
by the
आगे बढ़ो,
surgeon.
आगे बढ़ो.
Intra-articular breach or a post-operative breach can
Anyway.
occur just like DHS. That is the same thing.
This case is not included. Next.
Okay, no issue. No issue. I will put the slide. I think I have accidentally hidden the slide.
Nahi, go ahead,
The
you go ahead.
Yes, the issue is invisible instability even after the fixation and unwanted collapse pattern. Why? That is the problem. So there needs a biomechanical study. If you see this, the forces acting, that study has been done by Bergman in the Germany. Even in the sitting in the bed generates the same amount of forces. Sorry, it is stuck. Okay. 2-3 slides have gone just because of it was not moving. No issue, sir. So there are forces of flexion on flexion and extension. There are very high rotational and varus and bending in shear forces. It is not that the only lateral wall is important for a tension band. It prevents the varus also, and it gives rotational stability to the screws, because the screws only in the proximal fragment through the nail hole does not give that much rotational stability when lateral wall is intact. So it gives the lateral wall stability also. This is the study, and the forces are dynamic. It is not a static force. And many times we do not understand these dynamic forces where the anteroposterior direction, there is a vector translation. When the hip flexion extension is occurring, there is a rotation is also occurring there. So even after the reduction, there are large forces, and they are dynamic and the cyclic in nature. So we did a CT scan study, and we made a model. This is the unstable fracture where lateral cortex is relatively intact. Another where it was very badly comminuted. That is the problem area. So that is the issue. What the concept is, there is a continuous varus force, and there is a lateral band that is a dynamic force. The whole this bony part and the abductor that prevents the continuous varus force occurring as a cantilever on the this junction. So that has to be restored, otherwise it will go into the varus. Now imagine just in your mind when the lateral cortex is intact and you have drilled the hole and made a drill hole in the lateral wall like this, and that hole is coeccentric with the hole in the nail itself. So now your whole system is coeccentric. But when the lateral wall is not there, if you see, lateral wall is not there, what happens? The continuous varus force is there, and there is a varus, and the concentricity of that both bony canal, which was intact, and the canal within the nail that works as a barrel, just like a DHS barrel. It works like a DHS barrel. So that goes away. There is no concentricity. So that gets blocked. That axis gets blocked of the collapse. And there is a toggling of the instability, and that give rise to the Z effect or a reverse Z effect. That is a medial migration or a lateral migration. Or there can be a lateral migration of both the screws. That is also a possibility. It is a medial and lateral migration, and we are visualizing as a Z and reverse Z effect. With a single implant, there is a medial migration, as you see here, because that is a very good hold in the head and neck part. So what we have studied on finite element analysis is the part which is holding well in the head and neck part that gets hatched in. And the neck element which is not fixed well in the head and neck part, that on the hatching or the toggling that gets out gradually. That is a normal hatching mechanical process that goes with all the machines. And you see that even it can drop, both the pins can drop. It is not the reverse thing. When both the pins are dropping laterally, will you call it a Z or a reverse Z effect? There is no phenomena for that, coined for that. So it is virtually a medial migration or lateral migration. It is our visualization that we are giving it name as a Z or reverse Z effect. That is the issue. What is the issue is there is nothing to support laterally. And further violation we are doing with the large screws. As already Gottfried had said that we should not violate the lateral wall. That's why he reduced the size of the screw and provided the barrel to have a smooth sliding. And he supported the trochanter with extension of his plate. That was his first design. Another area is our jig. Jig is a single plane jig with all the PFN. And many times to centrally locate exactly in the center, many times we go posterolaterally and there is already a breach posterolaterally and we made that further. So we need a jig where there is a 2-dimension jig where it goes exactly in the center without rotating the jig and exactly 90° to the shaft, so that you do not require to rotate the jig to compensate the antiversion. You can see here one example where antiversion is maintained very well. Here is a nail and here are the screws. And as anatomy is reduced very well, the distribution of forces is like an intact bone. So we have to make the all complete anatomy. And at the same way, we are unable to preserve the lateral cortex. And when it is broken, we are unable to protect the lateral cortex. That is the issue. So on supporting the lateral side, we found that toggling has reduced and that has given us stability, further stability. But that is through the nail, through the plate, through the nail. And that is this is a slate plate. Reduction of the size of the proximal part to reduce the damage to the proximal part. And these pins are triflange and they are our smaller size. So it does not do any damage. This is one demonstration how to pass a nail. Let me show you a operative itself. There is nothing to support here. You can see there is no lateral wall. Here, even if you have done a good reduction, there will be a problem later on. So we have to support with the lateral plate, and also the Evans abductor that has to be brought back, because that gives a mechanical stability as well as the vascularity to the fragment, and that gives us a good result with the good function, as you see here. Another example, I will not go much. This was the live surgery we had done. Here, it was very much unstable. As G.S. Kulkarni sir has said, the banana fragment and split banana fragment, it was very difficult to reduce. Dr. Tanna sir had observed this because he was moderating from the audience itself. We got the good anteromedial reduction, as you said. It is must and it has to be maintained continuously, anteromedial reduction. But even after getting the good anteromedial reduction, there is a combination, and that combination that will made an unwanted collapse. So we supported this here with the plate. Here you can see it, and these are the post-op CT scan images of the same patient, and it gives the 360-degree stability in such a osteoporotic bone. So this is required in certain subset of the patients where we need this type of fixation. 92 years old lady. Another example, DHS failed due to lateral wall instability, and this was supported with this system. Here you can see, even with the neutral reduction, that remains the neutral. It does not allow neutral to go to negative. That is the advantage. It is not the reduction only. It is the stability which is much more important. Reduction is important 100%. But it is the lateral tension band dynamic has to be corrected. Here you can see, again, the greater trochanter is broken, lateral wall is broken. Surgeon is fixed with the PFN, but there is already a damage here. Surgeon was happy with the fixation, but here no Z effect or reverse Z effect. You can see here both the pins drop down on the toggling of the nail. So these phenomena can also occur, but we are not described in the literature. It is an instability even after the fixation. That should be the right term, I think so. Another example, fixed with that plate, and this is the follow-up after fixation with the follow-up. another case of Dr. Tanna sir, you can have any plate system. It is not the these plate system, but if you can have a plate system where the screws are going through the plate, through the nail, then it will be a one system. But anything you want to support, you need to support. I think Tanna sir will comment on this because he thought on table that it has to be supported. That's why he has supported it, probably. So do we need a union only, or what about the function? Are we ready to accept abductor weakness or a varus and a reduction of the horizontal offset? That we have to, there is a very good, great confusion of the medialization, good, bad, or ugly. Initially, we were thinking that let the medialization and occur and let it unite. But devil is in the details. Once we go in the more and more details and we want more function, then we have to be much more accurate. So at the end, the message is detect, preserve, be aware of the lateral wall, protect, beware of lateral wall, bring back the abductors, and think of dynamic stability, restoration of the complete tension band, not only the lateral wall. It should be a complete tension band, and then it works dynamically against the varus forces, and then it gives a very good result. Thank you, sir.
Okay.